Welcome to another episode from the Veterinary Medicine Digest, where we delve into the intricate world of animal health to bring you insights that inform and engage. Today, we're embarking on a fascinating and sometimes heartbreaking journey into the realm of neurological and pain disorders in our beloved feline companions. We'll be discussing two distinct, yet similarly challenging conditions: feline limbic encephalitis, often manifesting as a form of temporal lobe epilepsy, and a mysterious ailment known as feline orofacial pain syndrome. Both conditions can profoundly impact a cat's quality of life, presenting unique diagnostic puzzles and therapeutic hurdles for veterinary professionals and devoted pet owners alike. Imagine for a moment your usually serene cat suddenly exhibiting peculiar facial movements, as if chewing on an invisible piece of gum, or perhaps repeatedly licking their lips with an intensity that seems unnatural. These seemingly minor behaviors, often dismissed or misunderstood, could actually be the subtle, initial whispers of a significant neurological event originating deep within their brain. Then, picture a different scenario: your cat, perhaps a beautiful Burmese, suddenly recoiling in distress, pawing at their mouth, or even causing self-inflicted injuries to their tongue or face, seemingly in response to an unseen, agonizing pain. These scenarios, though different in their underlying mechanisms, highlight the often hidden struggles our feline friends can endure. Our journey begins with feline temporal lobe epilepsy, a condition that, while not an etiological category in itself, presents as a distinct syndrome strongly affiliated with specific anatomical structures in the brain, most notably the hippocampus. For decades, even as far back as the 1930s, the scientific community has been aware of the epileptogenic potential of these temporal lobe structures in cats through meticulous experimental research. Early studies, using various forms of stimulation to the temporal cortex, hippocampus, and amygdala, consistently observed a very specific set of clinical signs associated with these epileptic discharges. These early experimental findings, once largely confined to research papers, are now gaining renewed attention in clinical veterinary medicine, offering invaluable insights into spontaneously arising temporal lobe epilepsy in cats observed in practices around the globe. So, what exactly does a temporal lobe seizure look like in a cat? The characteristic clinical signs are often referred to as orofacial automatisms. Think of lip smacking, facial twitching, a noticeable gagging, unusual tongue movements, excessive salivation, and repetitive masticatory, or chewing, movements. These signs, while seemingly minor, are crucial indicators. Researchers have even developed a detailed 6-stage system to describe the sequential progression of these ictal, or seizure-related, clinical signs. Let's walk through these stages, as understanding them can significantly increase a veterinarian's awareness and recognition of this condition. Stage 1 often involves subtle behavioral changes such as looking around, sniffing, or an attention response, where the cat becomes unusually alert or focused. These early signs are often less obvious and quite difficult for an owner or even a veterinarian to recognize as part of a seizure. Stage 2 progresses to immobility and staring, a state often described as an arrest. Stage 3 brings forth those distinctive orofacial automatisms: lip smacking, facial twitching, chewing, swallowing, blinking, along with hypersalivation and mydriasis, which is the dilation of the pupils. This is where the signs become more clearly observable as a seizure. Stage 4 continues with more pronounced masticatory movements and facial twitching. Stage 5 can involve head turning or head nodding. Finally, Stage 6 can see the seizure progress to a generalized convulsive tonic-clonic seizure, though not all temporal lobe seizures will reach this generalized stage. The hippocampus, a key part of the temporal lobe, is particularly vulnerable in these cases. It's not only susceptible to epileptic seizures but is also highly epileptogenic itself, meaning it can readily generate epileptic discharges. This has profound implications because, following the wire together, fire together concept, the hippocampus's widespread neuronal connections make its network highly prone to excitotoxic changes. This means that damage to the hippocampus, in the form of hippocampal necrosis, or tissue death, can arise from various initial causes. Moreover, epileptic seizures, whether they start inside or outside the hippocampus, can trigger hippocampal discharges, ultimately leading to necrosis and, later, a more permanent change called hippocampal sclerosis, characterized by selective neuronal loss and scarring. In many cases, the precise initial injury leading to these hippocampal changes remains a mystery. Diagnosis of feline temporal lobe epilepsy often relies on characteristic clinical signs and supportive diagnostic imaging, particularly magnetic resonance imaging of the brain. Magnetic resonance imaging often reveals changes in signal intensity within the hippocampal region, which frequently correlate with hippocampal necrosis or sclerosis seen on histopathology. High signal intensity in water-sensitive magnetic resonance imaging sequences indicates increased water content, which can be due to various pathologies like postictal edema, inflammation, ischemia, or sclerosis. Hippocampal volume changes are also observed, with sclerosis often associated with volume loss or shrinkage. Interestingly, feline hippocampal necrosis can show homogeneous or heterogeneous contrast enhancement on magnetic resonance imaging, which is less common in human hippocampal sclerosis, suggesting some differences between species. However, magnetic resonance imaging alone cannot definitively differentiate the underlying cause of these changes. Ultimately, histopathological examination of the temporal lobe, especially the hippocampus, is critical for definitive diagnosis. The most common findings are unilateral or bilateral hippocampal necrosis and hippocampal sclerosis. Hippocampal necrosis is characterized by the pan-necrosis of neurons and glial cells, while hippocampal sclerosis, often seen in cats with prolonged or refractory seizures, involves selective subtotal loss of hippocampal neurons alongside astroliosis, a proliferation of astrocytes as a reaction to neuronal damage. These two conditions often represent a continuum, with necrosis potentially preceding sclerosis. Beyond these primary changes, other pathologies like inflammatory conditions, infectious diseases, such as feline infectious peritonitis or cerebral toxoplasmosis, autoimmune disorders, like autoimmune limbic encephalitis, and intracranial neoplasia can also be found concurrently. Now, let's pivot to autoimmune limbic encephalitis, a condition that has garnered increased attention in both human and veterinary medicine. In humans, autoimmune encephalitis is a recognized and significant cause of brain inflammation, with a prevalence comparable to infectious encephalitis. It's frequently linked to antibodies targeting specific neuronal proteins on the cell surface, which are believed to interfere with normal neuronal function, leading to symptoms like seizures, memory loss, and behavioral changes. One prominent form of human autoimmune limbic encephalitis is associated with antibodies against the voltage-gated potassium channel complex. Initially, the voltage-gated potassium channel itself was thought to be the direct target, but now it's understood that antibodies against specific proteins within this complex, particularly leucine-rich glioma inactivated 1 and contactin-associated protein like 2, are the true pathogenic mediators. While specific faciobrachial dystonic seizures are considered pathognomonic in human leucine-rich glioma inactivated 1 antibody encephalitis, they aren't typically observed in affected cats. In cats, the suspicion of autoimmune limbic encephalitis has been growing, particularly in cases presenting with acute or subacute onset of altered behavior, such as fear and aggression, and cluster complex partial seizures with orofacial automatisms. This clinical picture strikingly resembles what is seen in human limbic encephalitis. A landmark pilot study investigated cats with complex partial seizures and orofacial involvement, finding that 5 out of 14 affected cats, but none of the control cats, had significantly elevated concentrations of voltage-gated potassium channel complex antibodies. Crucially, in 4 of these 5 cats, the antibodies were specifically directed against leucine-rich glioma inactivated 1. This strongly supports the existence of an autoimmune limbic encephalitis in cats with a similar etiology to the human disease. What makes diagnosing autoimmune limbic encephalitis particularly challenging in cats is that, similar to human cases, the standard diagnostic workup, including magnetic resonance imaging of the brain and cerebrospinal fluid analysis, can often appear unremarkable. This can be surprising for veterinarians who typically expect inflammatory changes in brain infections. The absence of obvious lesions on magnetic resonance imaging might be due to the mild cellular inflammatory changes being below the sensitivity of standard imaging techniques, or the smaller brain size, making subtle changes harder to detect. However, more severe magnetic resonance imaging changes, when present, like hippocampal swelling or edema, or later atrophy, have been identified as a negative prognostic factor in humans and are likely relevant in cats too. Treatment for feline autoimmune limbic encephalitis typically involves a combination of anti-seizure medications and immunotherapy. Phenobarbital and levetiracetam are the most common anti-seizure drugs used, given their safety and efficacy in cats. For immunotherapy, prednisolone is often administered, especially in more severe cases. However, the response to steroid treatment can be complex. One study observed that cats receiving early prednisolone actually had a worse outcome, with a higher number of daily seizures and a greater likelihood of euthanasia. This counterintuitive finding is largely attributed to a selection bias, where only the most severely affected cats, including those without confirmed leucine-rich glioma inactivated 1 antibodies, received early steroid treatment, making it difficult to draw clear conclusions on its benefit in all cases. Despite these complexities, for cats that survive the initial acute phase, the long-term prognosis can be surprisingly good. Studies indicate that many cats achieve good seizure control and an acceptable quality of life with appropriate veterinary care and medication. Prognostic factors that seem to influence survival include the number of seizures at presentation and the severity of hippocampal changes seen on magnetic resonance imaging. Cats with a higher number of initial seizures or more severe magnetic resonance imaging changes tend to have a poorer outcome. Now, let's transition to a different, yet equally impactful, condition: feline orofacial pain syndrome. This is primarily a pain disorder, not an epileptic one, characterized by behavioral signs of acute oral discomfort and, quite alarmingly, self-mutilation of the tongue, lips, and buccal mucosa. It was first recognized in the early 1990s and has since been predominantly observed in Burmese cats. This strong breed predisposition strongly suggests an inherited disorder, potentially involving abnormal processing of sensory information from the trigeminal nerve, which supplies sensation to the face and oral cavity. The discomfort experienced by cats with orofacial pain syndrome is typically episodic, unilateral, and often has pain-free intervals. Owners frequently describe exaggerated licking and chewing movements, along with pawing at the mouth. These episodes can be triggered by various factors, most commonly mouth movements such as eating, drinking, or grooming. Other anecdotal triggers reported by owners include strong perfumes, sunshine, or even cold. Feline orofacial pain syndrome is suspected to be a form of neuropathic pain, a chronic pain state resulting from damage or dysfunction of the nervous system itself. It's often compared to human conditions like trigeminal neuralgia, which causes severe, episodic pain in the face, and glossidynia, also known as burning mouth syndrome, which manifests as a burning or prickling sensation in the oral mucosa, often the tongue, without obvious physical abnormalities. In many feline cases, discomfort in the caudal tongue seems to be a primary issue, leading to severe mutilation injuries. Several risk factors contribute to feline orofacial pain syndrome. A significant number of affected cats, about 63% in one study, had concurrent oral lesions. These can range from generalized gingivitis and periodontal disease to odontoclastic resorption lesions, endodontic disease, oral ulcerations, and even the eruption of permanent teeth in kittens. Interestingly, many affected cats first showed signs when teething as kittens, only to redevelop the syndrome later as mature adults. Environmental stress is another crucial precipitating factor. In about 1/5 of cases, orofacial pain syndrome events were directly linked to situations causing anxiety. Common stressors include social incompatibility in multi-cat households, the introduction of new kittens, catarrh having builders in the home, the death of a primary carer, or moving house. Psychosocial stress can dysregulate the body's stress and inflammatory pathways, potentially promoting central sensitization in pain disorders, which could explain the progressive nature of the syndrome. Diagnosing feline orofacial pain syndrome often involves a process of elimination, ruling out other causes of oral pain or trigeminal nerve dysfunction, as neurological examinations are typically unremarkable. While traditional analgesics like nonsteroidal anti-inflammatory drugs and opiates are often tried, they are frequently ineffective in alleviating the discomfort of feline orofacial pain syndrome. This is where antiepileptic drugs step in as a more promising therapeutic avenue. The effectiveness of antiepileptic drugs in feline orofacial pain syndrome is believed to stem not from their anticonvulsant properties, but rather from their antiallodynic effect, their ability to reduce pain caused by stimuli that are not normally painful. Phenobarbital and diazepam, for instance, have shown significantly higher success rates than corticosteroids in treating this condition. These drugs, along with others like gabapentin and carbamazepine, are thought to work by modulating various neural pathways involved in pain processing. For example, they can act on gamma-aminobutyric acid receptors, which play a role in inhibitory control of pain signals, or influence voltage-gated sodium and calcium channels, which are critical in nerve excitability and neurotransmitter release. Gabapentin, originally an anticonvulsant, has found particular utility in treating neurogenic pain, including refractory cases of human trigeminal neuralgia, by preventing the release of excitatory neurotransmitters. The pathophysiology of neuropathic pain, including feline orofacial pain syndrome, is complex. Researchers hypothesize that cats prone to this syndrome may have a dysfunction in the central, or ganglion processing of sensory trigeminal information. This could be due to a channelopathy, a disease caused by dysfunction of ion channels, specifically voltage-gated sodium channels, which play a key role in nerve signal transmission. Stress, as mentioned earlier, can also influence these channels, contributing to sympathetic hyperactivity and sodium channel upregulation. The outcome for cats with orofacial pain syndrome can be challenging. Many cases are recurrent, and the pain can become unremitting over time. Sadly, a significant proportion of affected cats, sometimes as high as 12%, are eventually euthanized due to the persistent and unmanageable nature of the condition. This underscores the critical need for early and effective treatment, including identifying and addressing any underlying oral disease and managing environmental stressors. For example, ensuring proper distribution of essential feline resources in multi-cat households can help alleviate social anxiety. Preventing self-mutilation, perhaps with an Elizabethan collar or paw bandaging, is also crucial, though addressing the underlying pain remains the priority. While feline temporal lobe epilepsy and feline orofacial pain syndrome are distinct conditions, they share some fascinating commonalities and challenges. Both can involve the temporal lobe structures of the brain and present with orofacial manifestations, though one is a seizure disorder and the other a pain disorder. Both are challenging to diagnose, often requiring careful observation and a process of elimination. And notably, both find therapeutic utility in anti-epileptic drugs, albeit for different primary reasons. To control epileptic seizures in temporal lobe epilepsy, and to manage neuropathic pain in orofacial pain syndrome. This highlights the complex pharmacology of these medications and their diverse impacts on the nervous system. The ongoing research into these conditions, drawing parallels with human neurology, offers hope for better understanding and management. Whether it's the detailed mapping of seizure progression in temporal lobe epilepsy or unraveling the genetic and environmental triggers of orofacial pain syndrome, every piece of knowledge helps us provide better care for our cherished cats. The collaboration between researchers, veterinarians, and owners is paramount in recognizing these subtle signs, pursuing thorough diagnostics, and implementing effective, tailored treatment plans. This commitment to understanding and compassion ensures that we continue to improve the lives of our feline companions, even in the face of complex neurological challenges. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.